Greetings from WINCARS. This World Heart Day, as we have the theme Use Heart and No Heart, we are here to discuss about the highlights from ESH 2023. The classification of office blood pressure and the grades of hypertension remain as we usually know them as normal, high normal, as previously, and so is isolated systolic and isolated diastolic hypertension defined. The guidelines recommend that blood pressure should be classified as we just now mentioned optimal, normal, high normal, grade 1, 2, or 3, according to the office blood pressure readings. But in addition to the grades of hypertension, which is based on blood pressure values, it is also recommended that we stage it. We stage it as stage 1, which is uncomplicated hypertension without any hypertension-mediated organ damage or diabetes or CVD, or without any CKD, which is more than stage 3. The stage 2 is when the hypertension-mediated HMOD, organ damages are present, or there is diabetes and CKD of stage 3. The stage 3 of hypertension goes as presence of CVD or CKD stage 4 and 5. So staging of hypertension besides the usual grading of hypertension is advocated by the guidelines now. Well, of course, they tell us to look at the risk factors by using score 2 or score 2 OP and look at the several other established and novel risk factors, like early onset hypertension, malignant hypertension, premature CVD, heart rate, even, resting values of more than 80 is one of the novel risk factor, as is the low birth weight, sedentary lifestyle, obesity, diabetes, hyperuricemia, lipoprotein A levels, and now even adverse outcomes of pregnancy are featuring into it, as is early onset menopause, and also, frailty, psychological, socioeconomic factors, migration, environmental exposure to air pollution. So many incoming novel risk factors besides the usual factors which were used for risk stratification as, sex, where men are considered to be more stratified than women, and age and level of systolic blood pressures, smoking current or the past history, and non-HDL. But several new novel risk factors have been added, additional clinical risk factors, the clinical condition or comorbidities to be included, like sleep disorders, as is obstructive sleep apnea, COPD, gout, chronic inflammatory diseases, NASH, chronic infections, depressive syndromes, erectile dysfunction, the HMODs as we all identify them. So these things have been included in the guidelines, and they also tell us to look if there is any established cardiovascular or kidney disease. Having said that, case finding or opportunistic screening for hypertension is recommended in all the adults. Regular blood pressure recommendation is a class 1 recommendation from the age of 40 years or even earlier in patients at high risk, and in individuals without hypertension. Intervals for repeated blood pressure measurement should be scheduled depending upon the BP level of the patient and the risk of hypertension and CV risk. In individuals with high risk, annual follow-up is recommended for these patients. Of course, we need to be very cautious when we are recording the blood pressures, all the precautions of where the cuff is placed, where the tubings are, how relaxed the patient is, whether the feet is uncrossed, whether the patient is talking, whether the patient is seated, what is the temperature, did the patient pass urine just before the recording, did the patient smoke or have caffeine or food intake. The usual precautions which are recommended have to be maintained, and we've already discussed about the grade of the hypertension and the stage of the hypertension, but we need to know that office blood pressure of more than 140/90 and in ambulatory BP readings, awake mean pressure of more than 135/85, a sleep mean of more than 120/70, 24 hours mean of more than 130/80, or a home blood pressure mean of more than 135/85 are the readings which are usually considered by the definitions. Well, of course, there has been enough stress upon when we need to consider to do the home and the ambulatory BP monitorings. We need to look for these readings when white coat hypertension is more common, as if when the patient comes with grade 1 hypertension in the office BP monitoring, or when there is marked office blood pressure elevation in the absence of any organ damage, So white coat hypertension, masked hypertension, and when we need to look at the treated individuals, whether they're having actual uncontrolled or true resistant hypertension, and we need to look in the high risk patients or in the patient is developing hypertension as in elderly patients. These are the patients who actually merit for home and ambulatory blood pressure monitorings. And if the patient is having postural symptoms, postprandial hypotension, or exaggerated blood pressure responses to exercise, these are the patients when we need to consider home and ambulatory blood pressure monitoring. Of course, when we need to look at the nocturnal BP status, dipping status, ambulatory blood pressure monitoring has an advantage over home blood pressure monitoring. And if the patient is not ready to get an ABPM done, or when we need a long-term follow-up and we want our patient to adhere, then home blood pressure monitoring can be considered. Of course, we need to look at hypertension-mediated organ damages as usual, and we know the criteria have to be looked upon in the ECG, in the echo, in the renal system. We need to look at their carotids, their retinal systems, any microvascular changes. Having said that, the protocol is important to understand. It's very interesting that, that the guidelines say that now if the patient is grade 1 or grade 2 and the patient is asymptomatic without any hypertension mediated organ damage or any cardiovascular disease, that means that the patient has grade 1 or grade 2 hypertension but is stage 1. That means the patient is asymptomatic and there is no organ damage or CVD there. Then we can call the patient again once after a month or so, after 4 weeks, and we need to look again at the blood pressure, establish the diagnosis, initiate lifestyle interventions. And if the blood pressure is less than 150/95, then maybe, we can initiate the treatment only if the blood pressure remains uncontrolled, and we should aim for an optimal blood pressure control at least within 3 months. However, if the patient is having grade 1, 2, or grade 3 hypertension, and the patient is symptomatic, and there is organ HMOD which is present, and CKD is more than stage 3 or CVD, then, we have less time, we initiate the lifestyle interventions and go ahead with the immediate drug treatment if the blood pressure is more than 150/95. And we aim for blood pressure control within the 3 months. Of course, across the arena, it has been now recommended to start with dual combination therapy, to upgrade to the maximal possible doses and to the triple therapy. We can use a once daily therapy early in the morning and add further drugs if at all they are needed. These drugs can be ACE inhibitors, ARBs, CCBs, or diuretics. Of course, beta blockers are also there, and we'll be looking across them in the coming slides along with the other antihypertensive therapies. Interesting is the addition of ARNIs, SGLT2s, and non-steroidal mineralocorticoid antagonists in the list. We are all aware of the contraindications to the usual drugs, which I'll not be discussing now. And we're also aware for the indications for the use of beta blockers, especially, these guidelines stress that when we have coronary syndromes, post-myocardial infarctions, arrhythmia, angina, incomplete revascularization, heart failure, acute coronary syndromes, HFrEF, HFpEF, atrial fibrillation, women who are having childbearing potential and planning pregnancy, hypertensive disorders in pregnancy. So beta blockers have got a special place in these indications. And in some other indications where beta blockers might be favorable are those patients with resting heart rates of more than 80, when we need emergency, urgency, and parenteral administration, in perioperative hypertension, non-cardiac surgeries, hyperkinetic hearts, postural orthostatic hypertension, OSAs, in the conditions where a patient is having thyrotoxicosis, hyperthyroidism, migraine-like headaches, tremors, anxiety and anxiety disorders, psychiatric disorders, and so on. So there's a special discussion of indications for the use of beta blockers, and we should know where we can use them. Well, a patient comes to us, let us start with a dual combination therapy. In step 1, we have a dual combination therapy using an ACE inhibitor, a CCB, and a diuretic, which could be thiazide or thiazide-like. and we can increase to full dose if it is well tolerated. In this step, 60% of them are controlled. In case the patients are still not controlled, then we need to go ahead to step 2, where we increase to full dose, and up to 90% of these would be controlled. A beta blocker can be used as a monotherapy or any step in of the combination therapy wherever indicated. Then if the patient is having true resistant hypertension, which is seen in around 5%, then we need to move ahead. Important is to understand that we need to start with monotherapy only, in select conditions like low risk hypertension and blood pressure less than 150 by 95, or a high normal blood pressure and a very high severe risk, or in frail patients and in those with advanced age. Having said that, we also need to look at the blood pressure lowering strategy in resistant hypertension, and that would depend upon what stage of CKD the patient is. If the patient is in CKD stage 1 to 3, we can add initially spironolactone to our usual regime of triple therapy of ACE inhibitor, CCB, and diuretic. So spironolactone or another mineralocorticoid receptor antagonist in stage 1 to 3, and then of course a beta blocker, alpha blocker, or a centrally acting agent. And still, if uncontrolled and EGFR is more than 40, renal denervation may be considered. In patient of CKD stage 4 or 5, we can add chlorthalidone or another diuretic and a beta blocker or alpha blocker and a centrally acting agent. Having said that, we need to now approach our patients with the age that we have. So in patients who are around 65 to 79 years of age, that means less than 80, the recommended threshold is 140 by 90, which is class 1. And the goal is to reduce the blood pressure to less than 140 by 80. And lowering below 130 by 80 may be considered if the treatment is well tolerated. And in patients from 65 to 80, these are all class 1 recommendation. Once somebody is, having 65 to 79 years old with isolated systolic hypertension, now this is the time when we need to lower the systolic blood pressure to 140 to 150, and this is class 1 indication. Less than 130 to 139 gets a class 2 indication, which is considered if the patient tolerates it well, provided the diastolic blood pressure is somewhere around 70. We have to be very cautious once the diastolic pressures are below that. And in patients in randomized controlled trials with isolated systolic hypertension, CCBs and thiazide or thiazide-like diuretics have mainly been used. However, other major classes can be used in these patients because of some compelling indications, as in one indicated, and the need of combination therapy might be used in patients with isolated systolic hypertension. And initiation of two-drug combination can also be recommended in most of the older patients with isolated systolic hypertension, especially the ones who are not frail. Once someone is beyond 80 years, the recommended office systolic blood pressure threshold for starting the treatment is 160 millimeters. So once someone is more than 80 years, however, a lower, threshold can be considered in select range, but that gets a class 2 recommendation. And office blood pressure should be lowered to systolic blood pressure in 140 to 150 range for systolic, and diastolic of less than 80. So the thresholds are significantly higher for starting treatment, more than 160 in the patients for office systolic blood pressure readings. And we need to target 140 to 150. And a lower target or a lower threshold can be just in select patients once someone is beyond 80 years of age. And if we need to lower further, that can be, but it has to be done very cautiously, especially if the diastolic pressure is already below 70. So when we look at treatment of hypertension, the guidelines recommend starting in presence of CAD, an ACE inhibitor with beta blocker. If angina is there, dihydropyridine, CCB might be added. In absence of angina, we can add either dihydropyridine calcium channel blocker or a diuretic. When we talk of treatment of hypertension and presence of HFpEF, it's very interesting that in the presence of dual combination, of either an ACE inhibitor, an ARB, and CCB, or a diuretic, initially we can also consider the addition of SGLT2 inhibitors. And in step 2 also they can be added, and beta blocker can be started in any of these steps in the presence of HFpEF. We increase the dose as tolerated, and if the patient continues to be hypertensive, it can be considered to substitute the RAS inhibitor by ARNI, or to consider the use of mineralocorticoid receptor antagonist, especially if the patient is in the lower spectrum of HFpEF. In the presence of atrial fibrillation, if the rate is more than 180 beats per minute, it's recommended to add a beta blocker to ACE inhibitor or ARB. If the rate is less than 80 beats per minute, we can go ahead with the addition of a dihydropyridine or a diuretic to ACE inhibitor or ARB. And then, of course, as we move over to other steps, we can add triple or quadruple therapy as desired and indicated, which could be a non-dihydropyridine CCB also if a beta blocker is not being tolerated. In presence of CKD, well, the steps remain the same. In stage 1 to 3 of CKD, we start with ACE inhibitor, ARB, and a CCB or a diuretic, increase to the maximum doses. However, if it's a true resistant hypertension and it's CKD stage 1 to 3, we can consider mineralocorticoid antagonist or spironolactone. Spironolactone is preferred. Of course, we can consider beta blockers, alpha blockers, or centrally acting agents. And if it's CKD stage 4 or 5, and in spite of adding the maximal doses of ACE inhibitors, ARB, CCB, and loop diuretics, the blood pressure is not controlled. This is the time when we can consider chlorthalidone or addition of another diuretic to the loop diuretic with the doses of beta blockers, alpha blockers, or centrally acting agents. Interesting is the addition of SGLT2 and Finrenone to the basic algorithm that we have. Having said that, I would like to thank you all, and I hope that these highlights of ESH, actually educate us and drive us to the thinking that we need to now have higher thresholds, especially for our elderly patients, for our frail patients, and we need to consider our patients not just with the grade of hypertension, but also now that we have the stages of hypertension, which are very important to understand when we treat our patients in the everyday practice. Having said that, I would like to now thank you for being around and together as WINCARS as we celebrate the World Heart Day. Let's use our heart and know our heart well. Thank you very much.